Good morning, everyone. Welcome to New Orleans. Welcome to the full-day course on cerebrovascular diseases. My name is Cheryl Bushnell. I'm Associate Professor of Neurology at Wake Forest Baptist Medical Center and Director of the Stroke Center there, and I'm the course director for the day. Can you? Okay. She's going to adjust the volume. We have a really nice set of speakers for you during the day today. We're going to cover the entire gamut from acute stroke to large intracranial and extracranial, large vessel disease. We'll talk about some clinical trials related to atrial fibrillation and stroke prevention. And a new facet of this course this year is to cover stroke in young adults, which I'll cover in a little bit later this morning. And also, we're going to cover some critical care issues related to intracerebral hemorrhage and subarachnoid hemorrhage. One change to the schedule is that our speaker, the final speaker for the afternoon, is going to be Karen Hirsch instead of Dr. Singh, who is unable to make it today, but the topic is the same. I have a couple of announcements. First of all, the traditional text syllabus, as you know, is available online, so you can download that. And then also all of the evaluations are online, so in order to get your CME, you actually have to fill out that evaluation online. And please give us your feedback on all of the courses that you, and all of the speakers. Please move to the center of the room just to make sure that there are enough seats for everyone. Hopefully we do have enough. Please turn off your mobile phones and pagers or silence them. And the AAN prohibits photography of any kind in educational programs. If you see someone recording the event, please notify AAN staff, the monitor, or the program director. All right, so without further ado, we'll start with our first speaker, who is Dr. Pooja Khatri from University of Cincinnati, and she's going to talk to us about the contemporary management of acute stroke.
Great, thank you. Can everyone hear me okay? Okay, great. So first of all, I want to thank Dr. Bushnell as well as the Education Planning Committee of the AAN for the opportunity to speak to all of you. So I'm going to talk about the contemporary management of acute ischemic stroke. These are my disclosures. So what I hope to do this morning over the next 45 minutes is give you a sense of the landscape in acute ischemic stroke, both what we know, what we should generally be doing, as well as a few things that are kind of on the horizon. So obviously that's a lot to cover in about 45 minutes, so feel free to, there'll be time for questions at the end if you'd like to talk about something in a little bit more detail. So I'll be covering reperfusion therapies for a lot of the talk, IV, endovascular, the role of time, imaging selection, and some practical tips. And then we'll talk about hospital management more briefly and what we know and don't know at this point. So as far as the reperfusion options, this is just to give you a framework, and I don't think this slide is in your packet, but I realized it would help frame the discussion. We know that from about up to 4.5 hours, IV TPA is effective. And I should say that it's well established within 3 hours based on 2 randomized clinical trials that were merged together in the NINS trial. And then also we have a positive randomized trial in the 3 to 4.5 hour window, and we're waiting for FDA approval on that. We've got the question of and reason to think that adjunctive endovascular treatment for the more severe strokes in that time window may be useful. And then once we get beyond 4.5 hours, things get a little bit murkier. We have data to suggest that IATPA or devices may be effective up to 6 hours. And then up to 8 hours, we have some data that I'll be showing you to consider or reviewing briefly to discuss about devices. And then within that timing, kind of the clock, there's the question of whether we can use imaging selection to optimize who to treat based on what we know and whether we can actually even expand the time window. So I'll be getting into that a little bit too regarding the reperfusion. So up to 4.5 hours. Like I said, and I sort of jumped the gun on myself, within 3 hours, we have Class 1 Level A evidence by AHA guidelines, 2 randomized trials and NIND studies. We have several community cohorts that verify those trials, and it's the only FDA-approved treatment for acute stroke at this point. It's been slow, as you know, to pick up in the field, but it's increasing significantly now thanks to stroke certification and ambulance triage. In the 3 to 4.5 hour, we now have the ECAS-3 trial. It was a randomized trial that showed a positive result. It's only one trial, so it's level B evidence. There was a pooled analysis of some of the older trials that used later time windows that just pulled out those 3 to 4.5 hour people and showed similar results, so that's supportive. There's also registry data out there that tells us that treating at 3 to 4.5 hours is probably effective, and it's currently cooking at the FDA from what I understand, so I would anticipate, and I'm purely speculating, that it would get approved in the near future. With all these data, when you pull them together, we know that time is brain, and I don't think anyone here, that's news to anyone here, but I just want to make sure that the degree to which time of brain is truly clear. We know that the number needed to treat to prevent 1 death or disability based on the NINDS trials is 8 within 3 hours. And I should note that the number needed to treat within 90 minutes is 2. So for every 2 people you treat, you prevent 1 death or disability if you can treat them within 90 minutes of symptom onset. The number needed to treat gets larger once we go to 3 to 4.5 hours. It goes to 14. So, more, but certainly worthwhile. And just to kind of give you a framework, I always find it helpful to think about this. The number needed to treat to prevent death after STEMI, the number needed to treat with thrombolysis is 26. So it gives you a sense, we have sometimes in the fields, especially in the emergency department, there can be such an urgency about STEMI, and I think that same level of urgency is sometimes lacking for acute ischemic stroke. So then the question comes up, you've got someone with a really severe stroke. Without getting into the details, we know that IVTPA leaves over half of people disabled, particularly those with the more severe strokes. And we think it's because we don't open up arteries as well as we'd like with IVTPA alone. So when patients have NIH stroke proximal arterial occlusions, if you happen to get baseline imaging to know that, or they simply have a severe stroke on clinical presentation, it's become more and more common to consider intra-arterial therapies. And that specifically, as many of you know, would involve basically, groin catheterization, taking a wire up to the brain, and either adding IATPA or adding devices. Regarding IATPA, we have non-randomized data from the IMS 1 and 2 trials and several others based on low-dose IVTPA followed by IA therapy. And there's been actually a ton of now full-dose TPA studies, mostly all case series and meta-analyses that suggest that you can give the full dose IVTPA and follow that by IA therapy. Adding devices is another question, and there is non-randomized evidence that it is reasonably safe based on what we'd want to see if you added the Mercy device, the Penumbra device, or the Solitaire device, and I'll tell you a little bit more about those in a few minutes. But the question still remains in the field whether we are gaining a lot by adding endovascular therapy. We know endovascular therapy has higher recanalization rates, and that's why we're really excited, and that's why we believe that it is likely to be better than just giving IV alone to severe strokes. But the fact remains that it takes time to get to the angio suite, and when you lose that time, you have more dead brain. So we also know that we tend to sedate these patients with general anesthesia in many centers, and then there are the added risks of just putting a wire up in the brain. So we don't know how that's going to pan out, but we think that there's reason to believe IA therapies may be better than IV alone. So we have 2 randomized trials going on right now, both of which I'm heavily involved with. One is the IMS-3 trial. It's 900 subjects, international. We're enrolling patients with NIH stroke skill scores of 8 or more within 3 hours of onset. And we're giving them they're getting randomized to either full-dose IV TPA or combined IV-IA therapy. And then they're getting treated within 5 hours, and the treatment is being completed within 7 hours. They have the choice of using any FDA-cleared device, whatever the interventionalist feels works best in their hands, given the clot that they're seeing. And the story is actually unfolding quickly, as I'll tell you in a moment. The therapy trial is funded by the company called Penumbra, which is one of the devices in the IMS-3 trial. And this is a 500-subject trial, but it's specifically sub-selecting for the patients where they think that where we think there'll be the highest yield to show a benefit of combined IVI therapy. So it involves using reconstructed non-contrast CT scans and taking patients whose thrombi are greater than 8 millimeters and then randomizing those patients in the trial with the idea that there's evidence out there that IVTPA never opens up clots greater than 8 millimeters, so this would be the perfect patient to prove the concept. So I'm going to just put out a teaser just because the suspense is killing me, but just so you know, our IMS-3 trial actually got put on hold last week at 656 patients, and this is what I can share at this point. This is the official notice. Our Data Safety and Monitoring Board recommended that the enrollment be put on hold effective immediately and that there were no serious safety concerns. So stay tuned. I think this will be very interesting for the landscape of acute ischemic stroke, whether it's positive or negative, and like I said, the suspense of all this is killing everyone, so we'll see. So then we go to beyond 4.5 hours. Well, IVTPA is off the table at that point, and I think at that point it's pretty clear that it's off the table. I mean, if you look at on the analyses of the older trials that went out to 6-8 hours with IVTPA, that you just started to do harm. Now, interestingly, I do want to mention that there is going to be a trial being released next month at the European Stroke Conference called the IST3 trial, where they put in patients that people wanted to treat and felt might help, but knew they didn't have data for it. So there's going to be actually a large subset of people being treated between 4.5 and 6 hours, and we'll see if there's any signal of benefit. But I would bet on there not being, just from what we've known before, but we'll see. So at least as of right now, the standard of care and what we know is safest and best for patients is to either do supportive medical care or consider intra-arterial lysis or mechanical devices. So as far as IA lysis, the brief story, many of you may have heard it before, is that we've had one randomized trial to date until the IMS-3 results come out. One randomized trial, the PROACT 2 study, and it randomized patients to medical management versus intra-arterial recombinant pro-urokinase, another lytic, not TPA. And that was within 6 hours. The bulk of the patients were 3 to 6 hours, and it was a positive trial. But it was a small trial, and there were some group imbalances, and while it was compelling, the FDA said, we need a second trial to approve this therapy. The second trial was never pursued by Abbott Laboratories, who funded that trial, and so that's the limit of our knowledge. And so with that, we've tended to extrapolate that it may be appropriate to do then IATPA, and that's the basis for doing IATPA within 3 to 6 hours. It sort of makes sense because we've shown that opening up the artery in that PROACT 2 trial conceptually can lead to better clinical benefit, most likely, and so taking that to TPA seems reasonable. So based on that, the American Heart Association guidelines suggest it's class 1. We should generally do it level B evidence. We've got one randomized trial that provides indirect evidence for this. The other trial that's out there related to this concept is the MELT trial, and it was stopped early in Japan, but when you pool MELT, it wasn't a positive trial, although some of the secondary analyses were, and when you pull MELT and PROACT together, as shown in the diagram below, you could basically see that it ends up being a positive result. So that's reassuring, too, as we think about how to take care of our patients. So if I've got somebody, beyond the 4.5-hour mark, but I still think I can get them on the angio table within 6, I think that is very reasonable and appropriate to take them. Now, mechanical embolectomy, we've got, device approvals work differently than drug approvals, and so for mechanical embolectomy, or for devices in general, you just have to show that the device is doing what it said it was going to do to get FDA clearance. So we've got 3 devices out there, and they're all cleared by the FDA to remove clots. They haven't been shown to benefit patients necessarily, although there's compelling evidence based on post hoc analyses that it may be beneficial. 510K clearance, the first one is the Mercy device. It's a corkscrew retriever, and it's been out since 2004. And then there's the Penumbra device, which is to aspirate the clot. And then the newest and probably hottest device right now that everybody's talking about is the Solitaire device, which just got cleared by the FDA in March of 2012. And the way that works is it's a retrievable stent. And so basically you dislodge the stent within the clot, and the clot kind of seeps in through the mesh, and then the idea is you just retract the clot out. And from what I hear from neurointerventionalists, it's just technically very easy, and they're really excited about it. So it's always tough to know because having been doing this kind of research for several years, everyone's always super excited about the new thing. Now everyone's kind of like, oh yeah, the Mercy device, it doesn't work that well. But at the time it was like, I can't even randomize patients in the IMS3 trial. I just can't do it. So keep that in mind as you hear the buzz, and I think we need more data. There is some more data, though, that really does support the buzz a bit. And that is the SWIFT trial. This was announced at the last stroke conference in February, actually, here in New Orleans as well, by Dr. Jeff Saber. And this was because the FDA, to make a long story short, has changed their way that they approve devices now. And so they're now requiring randomized trials between devices to show one does what it's doing better than the other, or at least similarly. So they randomized patients to the Solitaire device that I was telling you about, that stent retriever, and compared them to the Mercy device, that corkscrew device. And they basically showed significantly higher recanalization rates, opening up 69% of arteries compared to 30. I should note that this is probably the first controlled trial now since PROACT, and the only controlled trial that kind of put devices in, and the recanalization rates are a lot lower than you get reported in the literature just based on non-randomized studies. Not surprising, but I think it's important to note because we expected the Solitaire numbers to be 80 to 90% based on the retrospective data and the buzz. We expected Mercy to be 60%, and these are just lower than we expected. Mortality was higher without recanalization, again reminding us that recanalization probably does matter. And the good outcome rates were 58% in those with Solitaire, 33% with those with Mercy, although the reported rates were not your typical endpoint. It was a little bit broader and more liberal. So we'll see our usual endpoint for trials is modified Rankin 0 to 2, and they also added 10-point change in NIH stroke skill score. So I'm not sure where to put that in the scheme of things at this point, except to say that certainly this device looks promising. And with that, there are now 3 other stent retrievers, and I think we're getting to the point where it's all the buzz is just really high about stent retrievers in the endovascular world. There's the Trevo, which was made by the same company as Concentric, and they're going to be announcing their randomized data where they compare their own Concentric device to the Trevo device next month at the European Stroke Conference. Penumbra has incorporated a new stent retriever within their system, so it's just called the Penumbra system, but it has a separate piece called the 3D to give people more options, and that's currently acquiring data for FDA clearance. And then Johnson & Johnson has a device called Revive. And when I talk to interventionalists, it sounds like they're all very similar, but this class is definitely a step up in many people's eyes. So I think what I've told you at this point is that what we know about is that IVTPA started within 4.5 hours is beneficial. IA recombinant pro-urokinase, and then by extrapolation, IA-TPA is probably beneficial within 6 hours. And when we come to IA devices, they seem safe, started within 8 hours, maybe beneficial, and we need more data. What we don't know is when you get to the point where opening up an artery is futile, the brain's already dead. And what we don't know is with that, do we get to a point in our time frame where we're just introducing the risks of the procedure, hemorrhagic transformation with little or no benefit? So I think that, oops, I think I went the wrong way there. So we tried to look at this in the IMS 1 and 2 trial just to get a little more of an idea of where that time window might really end. And this has all the issues that happen when you go back and look at data and have a retrospective analysis. But what we did is we looked at the time in IMS 1 and 2 that arteries were opened up between 200 and 400 minutes. And then we looked at the probability of a good outcome from 0 to 100%. And you can see if we opened up the artery early, we were at 80, 90%. And as we went down, the likelihood of a good outcome reached the point of those of our cases where we didn't open up the artery. So we think at this point that 6 to 7 hour time window is probably where we can get the most benefit. But again, this is just hypothesis generating, and we need to figure that out for sure. But if you believe this graph, that's a really big difference in clinical outcome. A 30-minute delay is a 10% decline in clinical outcome. So whether you're doing IV or IA therapy, there's a reason we need to hustle in the ED and make things move as quickly as we can. Now, there's a lot of growing literature out there in the exciting field of imaging selection, moving beyond the clock. And the principle behind that is if you use penumbral imaging, whether it's MRI or CT, there's the concept that there's core, which is tissue that will inevitably die and be beyond salvage, whether that's diffusion restriction on MRI, or you could potentially look at CT changes on just a non-contrast CT to try to figure out what core is. And then there's penumbra, where you're seeing clinical effects of the decreased blood flow, but the brain isn't actually dead yet. There's also the area that will most likely survive despite decreased blood flow, and then there's the rest of the brain. And so the concept is, if we had a patient, and this is an example published by Dr. Greg Albers from Stanford, if we had a patient who was here 5 hours, 48 minutes after stroke onset, NIH stroke skill score of 16, severe stroke, and they have this really small area of diffusion restriction, and then we do the perfusion imaging by MRI, and we show that there's this larger area of penumbra, which is why they're as big as a 16 and not as small as you'd expect from that core infarct. And then we do an MRA, and we see there's a clot in the M1. Well, if we open that up, what we would imagine is that core would still be there, the penumbra would be gone, we'd have a beautiful result, and the patient's NIH stroke scale score would be 5. So that's the principle behind imaging selection, and it's very exciting. It would be great if we could extend the time window. We're not completely there yet, but we're getting there. And basically the idea is that imaging selection would allow us to basically come up with a different slope of this line for different people, because we'd have another way of seeing how the brain is dying based on a given patient's protoplasm. So as far as what we do know at this point, there have been several trials. To make a long story short, DS1, DS2, DDoS, Epithet, and they were all pooled, and they were all negative trials by themselves. But when they showed safety, hypothesis-generating evidence to do larger definitive trials, but none of them kind of showed we should be doing this now. And so Dr. Mishra from Glasgow pooled these studies together and asked the question, did a favorable clinical outcome occur more frequently in the thrombolyzed group of mismatched patients? And he couldn't show that, but it did go in the right direction. In other words, this line, you had to go past this line to have a statistically significant effect, and it doesn't reach statistical significance. So we don't truly know yet, but it's a promising concept. One of the things that makes it really hard to use imaging selection in clinical practice is that each of these studies use very different definitions, and I know you can't read this table, but it's just to remind me to show you that this is out of Dr. Mishra's paper, that the methods used to evaluate mismatch were completely different. How the mismatch was, the perfusion metrics to decide how much mismatch there was were different. The actual definitions of mismatch were different. And so there's still a lot of questions in the field, and we need randomized studies at this point to assess the mismatch paradigm. We have single-arm studies showing that safety with IA treatment, and actually with IV treatment as well, I should say here, that's an error, and that more benign outcomes seem to occur potentially in untreated patients with mismatch, kind of making it hard to interpret what's going on. that being said, I think imaging selection is kind of out there and commonly used in clinical practice. I personally, I think it's premature, but I think that it's, promising. So at this point, these are the ongoing clinical trials looking at mismatch. There's MR Rescue, which was a small trial, really kind of to show feasibility and early data, comparing embolectomy versus medical management within 8 hours, and basically stratifying randomization to those who did have mismatch and those who didn't have mismatch. And so it's a phase 2 study. Probably won't give us an answer just based on the numbers. It's not powered to do that, but it should give us some interesting information, and that'll be announced next year at the stroke conference. There's the Extend trial comparing IV TPA versus medical management within 4.5 to 9 hours based on the presence of penumbra using MRI. It's a phase 3 trial, and that's going to be very helpful, I think. And then Dr. Albers is, a lot of the data out there is for MRI, and yet a lot of what we do in clinical practice, those that do imaging selection, is with CT, and we really don't know how CTP is going to match up with MR perfusion. And so Dr. Albers has an ongoing trial right now where he's doing CT penumbral selection and actually trying to understand how CTP and MRP match up. So I'd like to move on now to talk about some practical considerations, knowing this landscape, this theoretical landscape of taking care of your patients regarding reperfusion therapies. This is a graph that has been shown several times in different data sets. It shows the time from symptom onset to emergency department arrival and the time from emergency department arrival to TPA treatment. And basically, the bottom line is the earlier they are, the longer we take to treat them with TPA. The later they come, the faster we are. So it's kind of human nature, but as I showed you, that we're talking about big differences in patient outcome with those delays, even though that time window is still there for you to treat. So with that, that's a big push in the field, is to try to speed up. I think in Europe they are substantially faster than we are, and I think there's a lot we can do in our systems to speed up. These have been the NIN's recommendations for years, and they're very achievable, but they're not as widespread as they should be across the United States at this point. The idea is that the ED physician sees the patient within 10 minutes. The stroke physician is notified within 15. The CT scan is completed within 25 minutes. The CT is interpreted within 45 minutes. IV TPA is initiated within 60 minutes. So we're striving for 60-minute door-to-needle times. And most experienced stroke centers do reach that, so it is very achievable. And then if you're going to do IA therapy, the idea is you should clearly move as quickly as you can. If you think it's right for this patient, every minute counts. So as far as treating with IV TPA more quickly, one of the things that I think is incredibly helpful is activating the stroke team prior to the CT so that the stroke team can start heading over, turn around if it's a bleed. But this is going to make a big impact on patient care. And I think one of the things that just kind of the high yield points is that glucose is actually the only lab you need before you treat. You don't need to wait for the other labs unless you have a clinical suspicion of other abnormalities. So it's been shown by Brett Kuchera and colleagues that only 6 out of 1,572 patients with unsuspected thrombocytopenia had it. So that's a 0.3% rate, and that's a risk worth taking to treat quickly. And then Natalia Rost showed that an INR of greater than 1.7 among those that you didn't suspect it had a 0.4% yield. So again, you don't need to wait for labs. Just move as quickly as you can. Another tip, storing the ED in the Pyxis of your hospital. Some hospitals don't like that. They say it's an expensive drug, and they want to control when you get it. But you could easily lose a half hour right there, and I've been there, and it's very frustrating. It really needs to be in the ED Pyxis. And Genentech does reimburse people who mix the drug and then don't end up using it. So that's something to keep in mind as well. There isn't that much of a risk as far as finances go. And so mixing the TPA early for that reason makes a lot of sense. So I want to just show you in the cardiac world how the interaction between time and IV TPA and IA therapies, I should say IV lysis because they use more than just TPA in the cardiac world. And this is data that's pulled from 20 trials and 50,000 subjects. The cardiologists do much larger scale trials than we do. And they basically showed This is your treatment delay. So this is the time when you arrive to the ED and when you get treated, from 0 to 24 hours. And this is the absolute benefit of that treatment per 1,000 treated patients. And they basically show that if the door-to-balloon time is less than 90 minutes, lysis with IV is likely of greater benefit than endovascular therapy. And that line kind of crosses over, and endovascular therapy becomes more significant later on. So you imagine that maybe that's where the field is going. We don't know it all yet, and like I said, maybe we'll be figuring some of that out with the IMS-3 trial soon, we'll see. But in the meantime, it just drives home the point that you've got a severe stroke. You know that IV TPA is not going to necessarily give you the results you want. You decide it's an appropriate patient to push for endovascular therapy. Well, plan for transport early. Call the endovascular team the first minute you're thinking about it so they can start dropping what they're doing. Make sure they have their IV lines and Foley catheter in place. Make sure your endovascular seat keeps flushed bags for their IA cases, and consider not sedating the patient, which in the field right now is a very mixed approach, and I think it does add time, and it's fairly controversial, but it's something to consider. So for the last 15 minutes or so, I'm just going to switch gears and talk about things other than reperfusion therapy. There's a lot of other things we do to help our patients get better. And as you all know, there are basically two very well proven things for improving outcome after acute ischemic stroke. One is reperfusion with IV TPA, but the other is stroke units. We don't know exactly what about stroke units, but it's clearly the milieu of all that we do. So in that setting, that just go through what evidence we have for what we should be doing in those stroke units. Well, one of the harder questions, and I've started with the hardest first, is optimal blood pressure management. We really don't know the answer to that. There's some evidence that maybe we should keep it the same, maybe maintain their home blood pressure meds. There's some evidence that maybe we should lower it and start new blood pressure meds. There's lots of speculative evidence to increase it, to increase cerebral perfusion pressure and minimize the infarct size. And at this point, when you put it all together, the class 1, in other words, this is what we all think, level of evidence C, we're really not sure at all, we don't know, this is just theorizing, is to allow the blood pressure to go up the way it's going to, up to about 220/120. So we really don't know the right answer, and whenever I have a compelling reason, like they've got comorbidities like cardiac disease, I don't think twice about lowering their blood pressure. Obviously, if they become symptomatic, then I do. And this is based on the 2007 guidelines, and I would suspect that the next guidelines are going to be very similar. Hyperglycemia. So hyperglycemia during the first 24 hours after stroke is associated with poor outcomes. And there's lots of evidence for that in a whole bunch of different animal models, trials. But whether actually fixing that and how aggressively to fix that to improve patient outcomes should occur, that isn't as well known. So at this point, the recommendations are that we treat glucoses possibly greater than 140 to 185, and that should trigger the administration of insulin. That's a 2A level C evidence. And the tighter control may be of more benefit. And I know that there are a variety of practices out there, and I can't, I think at this point it's still not clear which is the best way to go. But thankfully, there's a trial going on right now called the SHINE trial, led by Karen Johnston at University of Virginia, and I think they actually just they just started enrolling in the trial in the last few days. And what they're doing is they're randomizing 1,400 patients within 12 hours of symptom onset to either very strict glucose control, maintaining them with glucoses of 80 to 130 for 72 hours, and seeing if that's going to be better than just sliding scale insulin to maintain patients less than 180. It's fairly laborious to do this, and so I think having that evidence will be very helpful and could potentially change the standard of care for us. Antiplatelet therapy, well, that's clear-cut. All patients should be started on aspirin, 325 milligrams. The evidence is for within 48 hours, but just logically, it seems like sooner is probably better, and I would say most places do it in the ED once you know you're not going to treat with IV TPA. And the evidence suggests that we'll prevent one recurrent stroke over the next 2 weeks for every 100 patients we treat with just that aspirin. So it's an easy thing to do, give it per rectum if they have dysphagia, and it should just be kind of a knee jerk. One of the studies going on that will be very interesting is, and about halfway along now, a very large study called the POINT trial, led by Clay Johnston at UCSF. And what they're doing is they're randomizing patients to either standard of care aspirin or aspirin with Plavix loading and continued aspirin for the first 90 days, and TIAs and mild strokes. And the thought is that, things are kind of unstable when you've had a TIA or a mild stroke. We know there's this early risk of recurrence or worsening, and maybe we can kind of keep that at bay with more aggressive antiplatelet therapy up front, although we know in the long term that's not going to be beneficial based on the MATCH study. So finally, hemicraniectomy. At this point, there have been 3 randomized trials suggesting that if you have a patient with a severe malignant MCA stroke and you do hemicraniectomy, for every 2 patients you treat with hemicraniectomy, you prevent 1 death, and for every 2 patients you treat, you also prevent 1 disability. So pretty powerful numbers in a pretty severe disease, and it's always a very challenging decision whether to take a patient to hemicraniectomy, but I think the evidence is there that it does improve outcomes, and whether that improved outcome is what a given patient wants to do needs to be a discussion between the physician, the patient, and their family, and typically the family and the physician about what that patient would have wanted done. The data is so let me just go through the modified Rankin score, which is our very standard endpoint in stroke. A modified Rankin score of 1 means no significant disability. They're able to carry out all their usual activities. A modified Rankin of 2, slight disability, some limitations in prior activities, but they can still manage their own affairs. So typically, the bigger trials, the broad stroke trials will strive for a modified Rankin of 0 to 1, but then the stroke trials that include more severe patients will strive for a modified Rankin of 0 to 2. Moderate disability, a 3, is requiring help but able to walk. So they still need help doing their bills, they might need help taking care of themselves, going to the bathroom, but they can actually do the walking with themselves, whether it's with an assisted device or by themselves. Moderate to severe disability requires assistance to walk or carry out bodily needs. Severe disability is constant nursing care, bedridden. So this here shows you, in the green is conservative treatment of patients with herniating middle cerebral artery strokes, and this is a modified Rankin of, I guess I'm sorry, my legend isn't right there, but it would be a 2, 3, 4, 5, 6. That's right, because there was no one with a 1. So the green is 2 here, and the pink is 3. And that's with conservative management. And there you see with surgery, the green is 2, the pink is 3. So it seems that you get people to potentially a less disabled state, and then you get a lot less people dying at the end, which is a 6 here. So that really sums it up. And so our protocol at Cincinnati is that we basically consider patients using the same guidelines as the data that proved that hemicraniectomy is beneficial. We offer it to patients who are 18 to 60 years. We sometimes push the envelope to 65 years if it's somebody who is in relatively good health. NIH stroke score greater than 10 triggers us thinking about it, greater than 50% of the MCA territory, and then agreement of the available family. So usually what that means is that in patients who meet these first 3 criteria, we typically keep them in a neurocritical care unit, monitor them closely, and at the early signs of simply drowsiness, we scan them with a CT, and if we see midline shift, that's when we want to take the patient to neurosurgery, because obviously once you've compressed the brain further and killed more brain, that's sort of the cat's out of the bag, and so early is better. We do wait a minimum of 6 hours after TPA treatment, and then we have a heart-to-heart discussion with the family about this patient, what they value in life, what their quality of life would be, and whether they would want to survive in this state. So it's becoming more and more common, I think, to do hemicraniectomy, but and there are cases where I felt very glad that I offered that, and I felt the patient had a meaningful recovery for them. But I find this story particularly compelling, and so I'll end by mentioning this. So this is a quote from Neurocritical Care by a cardiac anesthesiologist who suffered a malignant MCA stroke, and I'll just read it to you. He said, I am a cardiac anesthesiologist with a doctorate in cardiovascular pharmacology. I hold degrees from Princeton and Columbia and trained at the University of Pennsylvania. Until the age of 49, I was the chief of cardiac anesthesiology at St. Joe's Medical Center in Towson, Maryland, directing the largest open heart program, 1,400 cases per year in the state. Concurrently, I was chairman of the hospital's IRB and associate editor of anesthesiology. This is not the life I enjoyed prior to my stroke. He's talking about being post-hemicraniectomy, having recovered from his malignant MCA stroke, nor is it how I envisioned spending my 50s. However, it is still a life worth living. I only have it due to aggressive interventions I received after my stroke and the therapy I continue to pursue. So it's just something to keep in mind, is sometimes I think the hospital systems aren't set up to do hemicraniectomy as aggressively. A lot of times the neurosurgeons aren't as excited about doing it, but I think we owe it to our patients to at least offer it. So what I hope is kind of the takeaway from this talk is that within 4.5 hours, you should start IV TPA and consider adjunctive therapies in select patients, and watch closely as we get more data out from our upcoming clinical trials about how to select those patients. From 4.5 hours, consider intraarterial therapies alone, and just remember that every minute counts. Regarding hospital management, allow permissive hypertension, treat hyperglycemia, start aspirin early, and if it's severe, consider monitor for malignant edema and consider performing an early hemicraniectomy. So with that, I will conclude. Thank you, and I'm happy to take some questions at this point. So if people can go to the mic and introduce themselves, that would be great.
Yes, I'm Mr. Rosta, Miami. I would like to ask you, if the patient had a seizure or two and came to the ER with a laceration in the tongue or in the lip, is the patient still a candidate for RTPA? And second, what do you do with the blood pressure? Because you're saying that you have to be permissive, but the criteria for RTPA administration require 185 or 105. And sometimes when they try to control the blood pressure, they drop it in the ER. So how permissive are you with the blood pressure prior to RTPA?
I'm glad you asked those questions, because it's so hard to cover it all in this talk. I'm giving a talk later in the week where I'm going to discuss kind of the practical issues of making TPA decisions. So the first one about seizure at onset and laceration, that would not prevent treatment of TPA. It's, you can compress that area. So I wouldn't let that stop you, and I think that's pretty clear cut. The second question was
blood pressure.
Blood pressure, thank you. So the blood pressure guidelines I provided were for non-TPA candidates, general hospital management, but for TPA candidates, to treat them with TPA, their blood pressure has to be below 185 over 110. Plenty of evidence that that's a risk factor or maybe a result of hemorrhage, who knows, but the bottom line is that's who we've got the data about. So if patients come into the ED and their blood pressure is, say, 200 systolic, what I'll first do is just give it a few minutes if they've just arrived and they called me, because it will go down a little bit. And if after those few minutes their blood pressure is still above 195, I'll very gently treat it. I don't want to over-treat it, so usually labetalol 10, and then I'll try labetalol 20, and then I'll move on to something like a nicardipine drip or an enalapril and just get them to that point. And then I'll maintain that to less than 180 over 105 for the first 24 hours post-TPA. When that's done, then I'll go to what I just described.
Thank you very much.
Thank you.
Adam Heller. The things that seem to be missing from, I guess, current guidelines, or with the use of newer oral anticoagulants, guidelines either for lab values, or do we just not know right now, or what do we do with presenting with those patients on either Predex or Xarelto or whatever's coming next?
Yeah, it's a great question, and you're going to get a little more about the oral anticoagulants from one of our upcoming speakers who's going to talk about them in the context of treating atrial fibrillation. I'll tell you the punchlines from the acute ischemic stroke decision-making standpoint, which is there's no lab test to help guide you at this point, and you could think about it a number of ways. I know that the acute ischemic stroke guidelines are going to be updated and coming out hopefully soon. They're a little slower than I expected, hopefully within the next 6 months. And we'll have some guidance there. But if if you just think about the half-life of the novel, the new anticoagulants, it turns out that it's still probably in their system about 48 hours from the last dose. And so generally, at least what we're doing right now at our center is thinking when they're 24 hours out from their dose, they're probably less anticoagulated, and we could think about it, but frankly, I feel very nervous because I have no idea what I'm doing there. But after they're 48 hours from the last dose, I think you can feel pretty comfortable treating them. So if they missed a couple doses, you're in good shape. Beyond that, there's a registry now being developed by Dr. Grata in Houston of patients that are being treated in this setting, and then hopefully we'll know a lot more. So.
Hi, Stephen Burton. Do you have any guidelines on how much bone you remove for a craniectomy? My impression is sometimes the surgeons take too small a piece.
Yes, you know, frankly, I don't know the answer to that question off the bat. I could get it for you. There's my email. And if others can weigh in, I know there's some other stroke physicians here, but what I do know is there's definitely a too small amount, and we actually had that happen with a case, and we sat down with our neurosurgeons and talked about how much bone to take out, but I can't tell you the precise definition.
George Bacquis, you devoted a lot of your talk to intra-arterial therapies, but many hospitals don't have individuals who are specialized in doing that sort of thing, and even if they do, they don't see large volumes. So I have two questions. The first is, can you comment on the safety of doing those procedures related to volume that individuals who perform these do? And the second is, could you just comment on how you integrate giving IV TPA with intra-arterial therapy if it involves, shipping a patient out, and how you approach that?
Yeah, those are great questions, and it's a moving target because we've got a major trial answering this question that's just been held, and hopefully is going to have a lot of data in there once we get those results in our hands. And so at this point, based on just what I know, I would say that there's enough evidence to make you think that in certain patients it's a reasonable approach to do endovascular therapy, and having a relationship with a hospital that provides endovascular therapy would be appropriate. It's not unreasonable to hold off. It's certainly not, class 1 evidence. It is slowly becoming the standard of care in the United States. So that's kind of a wishy-washy answer because I think it's a really tough question. I will tell you that the comprehensive stroke center guidelines that are going to come out are going to require that those hospitals have 24/7 endovascular coverage. And to be a primary stroke center, you have to have a relationship with a hospital where you can make that transfer. So that's kind of the infrastructure out there that's building. Does that answer your question a little bit?
So in terms of, the patient who comes in acutely, though, IV TPA is still the standard of care.
Still, yes.
So the patient should get full dose therapy? Absolutely,
absolutely. And none of those other thought processes delay it. And I think, the field is moving towards endovascular therapy, and in some cases faster than the data, so there's that. But clearly the standard of care at this point is IV TPA.
Okay, thank you.
Thanks. I'll take one more, maybe the last one, I think.
Hi, Brian Jenkins. Are you aware of any data regarding pressors, use of pressors to artificially?
Yeah, I think there's a trial in Europe looking at that, but no, there's no kind of, there are case series suggesting maybe it would be better, but there's nothing that kind of you can hang your hat on and say, I clearly should be doing this. So what I do is I let people ride high. If they worsen, and I think, well, maybe blood pressure raising could help, I give them a fluid bolus. I think that's what a lot of us do, and we see. And if they respond to that, then I might even give pressors as well and say, and think, okay, this is someone who's looking perfusion dependent. But that's kind of a case by case, and that's, me just trying things. So thank you.
Thank you so much.